I would like to start by thanking the organizers for giving me this opportunity to present some findings from an mHealth-based screening study. In this presentation, I will be discussing HIV, smokeless tobacco use, and oral potentially malignant disorders. To give a brief background on the rationale for our work, oral potentially malignant disorders, or OPMDs, are chronic lesions or conditions with the potential for malignant transformation, and they therefore serve as important clinical events for the introduction of preventive services like screening. It is well documented that smokeless tobacco use is a risk factor for OPMDs, and this is particularly concerning for South Asia because of the total burden of smokeless tobacco users. 90% of them reside in the region. In a recent Lancet review, it has also been documented that South Asian PL-HIV use smokeless tobacco much more commonly compared to HIV uninfected persons. Despite this high use of smokeless tobacco in the region, data on association between OPMDs and smokeless tobacco use among PL-HIV remains abysmally scarce, and this limits the development of preventive measures. In order to address this research gap, in this analysis, we assessed the association between OPMDs and smokeless tobacco use among PL-HIV. We used data from a cross-section study that was based in the ART clinic of BJ Government Medical College, Pune, India. Our study population comprised of approximately 1,200 study participants, of whom about 50% were PL-HIV. We kept the inclusion criteria deliberately broad in order for our results to be more reflective of real-world conditions. Now, as part of study procedures, socio-demographic, clinical, and risk factor details were collected, along with 8 images of various parts of the oral cavity on mobile devices. This data was then synced onto a cloud-based server from where it was accessed by 2 clinicians who independently diagnosed the images as OPMD yes or no. These clinicians were blinded to the HIV status of the participants and not provided any risk factor details. Because we wanted to use prevalence ratios as measures of associations in this analysis, we fit Poisson regression models with a robust estimation of standard errors. As part of sensitivity analysis, assuming non-differential misclassification error of the outcome, we use different sensitivity and specificity parameters specified in literature for the use of remote image diagnosis when compared to in-person clinical examination to obtain correct prevalence ratios. Descriptively, we observed that OPMDs were much more commonly diagnosed in the group of PL-HIV as compared to the HIV uninfected group. The proportion of current smokeless tobacco users was, however, equal in the 2 groups. When we specifically looked at the duration of use among current smokeless tobacco users, we observed that use was much more prolonged in the group of PL-HIV as compared to HIV uninfected individuals. Results from our regression models indicate that the prevalence of OPMDs was higher among PL-HIVs. Now, when we restricted our analysis to PL-HIV exclusively, we observed that the prevalence of OPMDs was almost 5 times as high among current smokeless tobacco users than when compared to never smokeless tobacco users. Now, in corrected models, this prevalence ratio could range between 5.04 to 61.79 under different sensitivity, specificity, and prevalence parameters. When we looked specifically at current smokeless tobacco users across HIV status and duration of use, we observed that the strength and the direction of the association was similar to that in Model 1. So our results indicate that among PL-HIV, current smokeless tobacco users have a higher prevalence of OPMDs compared to never and former users. And for similar duration of smokeless tobacco use, the prevalence of OPMDs among current users is higher among PL-HIV compared to HIV uninfected individuals. Now, these results provide some preliminary evidence for us to consider the benefit of the introduction of screening services for current smokeless tobacco users in regular HIV care programs in the region. I would like to conclude by thanking the principal investigators of the study, Dr. Sameer Doshi, Dr. Chichikala Sangle, and Dr. Vidya Mave, the entire Treat Asia team at BJ Government Medical College, and all our study participants without whom none of this work would be possible.